And now to clean up, we have from our University of Louisville, Dr. Jason Chesney, who is the head of the Cancer Center and also the lead of our various forms of TILS therapy that we're giving. And so Jason's going to give you a great overview of this very interesting therapy.
I think I can figure that one out. I think he put me last because he figured you all would be gone by now. So I'm kind of your comic relief here. There's going to be a little bit of history in here, a little bit about immune checkpoint inhibitors, and then I'll go straight into TILs. And we've been working on TILs now for almost 10 years, actually, at the U of L. So when I moved to Kentucky in 2002, and when I got here, I decided my PhD is in immunology, so I decided to do melanoma, because melanoma, as most of you know probably, is like the poster child for immunotherapies. It has the highest mutation rates and all that stuff, and I knew that it was going to work, but I didn't know when it was going to work. And my mentor was Don Miller, and he was doing an IL-2 trial with GP100 at the time when I got here. And back then, stage 4 melanoma, you had about 8 months typically. I think that was the median overall survival for those patients. And we would just put them either on a trial with IL-2 or a trial with biochemotherapy and basically accelerate their death and basically practice palliative care. That's how it started. So I realized very quickly within a few years that every patient should go on a clinical trial. And that was my personal opinion at the time. And the first one that I picked out was a relatively unknown company that I'm not allowed to say because this is CME, I guess, but it was an antibody targeting a protein called CTLA-4 that I had been following when I was in the lab, and I knew Jim Allison and what he was up to, and I said, oh, we got to do this. So I got the phase 1 trial at the U of L, and we did the dose escalation trial, and it was a complete failure. We had a similar response rate to dacarbazine, which was developed in the 1970s. It was like 15% or something. And all my friends and my bosses and the surgeons were all laughing and saying, yep, another failed immunotherapy trial. And after I think it was about 3 or 4 years, we realized that we had this small subset, about 20% of patients who were still alive. And that was all confirmed with the trial and follow-up studies. And I think there was one at 7 years and then one at 10 years. And you got this nice shoulder on the survival curve. And then 2012 comes along. So that was 2006, I think. And we got the FDA approval in 2011. That was really the first big one, in my opinion. And compared to high-dose IL-2, which I can't remember anybody we cured with high-dose IL-2. So 2011 comes along, and right around the same time we get that FDA approval, the PD-1s start flying in the door. And the first trial that I opened up with a PD-1 wasn't the dose escalation trial, to tell the truth. It was this one. This was a phase 2 trial we did. And I can tell you that if you're no one here does melanoma, I assume, because I haven't heard any melanoma talks. If you're a melanoma doctor in this would have been 2012, and you start treating patients with ipi/nivo and you get a waterfall plot that looks like that, you're basically jumping for joy. I mean, it was just absolutely incredible. And we had no clue at the time that we were going to get durability, because this was coming right off of the the first BRAF inhibitor, that was vemurafenib. And, it worked great too, but within about a year, everybody progressed and died. But this turned out to be extremely durable. We were one of the top 2 sites in the country for this. And to this day, this is the frontline therapy for stage 4 melanoma. And I actually moved into non-small cell lung cancer predominantly because of this trial, because I wanted to do a trial at U of L, and I couldn't get any of the lung doctors to do it. So I started doing the trial, and that turned out to be a positive trial as well. And this is an example of one of our patients. And you can see, let me grab this is so old school with the little pointer. I like this. So you see this chest wall mass right here, right? I had the little asterisk right there. And it basically, after ipi/nivo, it looked like a surgeon had cut the damn thing out, right? I mean, it was gone. It was just absolutely incredible. And we see these, what I would call nothing short of a miracle, happening all the time when you give ipi/nivo to a stage 4 melanoma patient. The stuff really does work in about 60 to 70% of patients. But it doesn't work in everybody. And that is, I think, the greatest challenge in oncology right now. Why do these PD-1 inhibitors and CTLA-4 inhibitors and LAG-3 inhibitors work in some people and not in other people? And it's probably going to turn out to be a lot of different reasons. And a lot of researchers are trying to figure it out. Oh, sorry, I forgot we're having lunch, so I thought I'd show this picture. That was the chest wall mass. So as you all know, and I think we just heard that, this is just from a paper this is from 2021 that I ripped off the internet, but it just introduced the idea that you could try this in all cancers, because all cancers have mutations that can be seen by cytotoxic T cells. And this is only going through 2020. I think the most dramatic thing that happened that changed a lot of things is this one right here, the tumor agnostic one, where you just need a TMB that's, I think it's 10 mutations per megabase. So you can treat anybody with pembrolizumab now. They just have to have the right number of mutations for it. And so talking about resistance, and this is from my friend Kavitha Yanapudi, but TAMs, tumor-associated monocytes, T regulatory cells, fibroblasts, all these things are in the tumor microenvironment and can turn off T cells, basically. And one of the most common, I remember looking at the data with the ipi-nivo trial and trying to do a sub-analysis of the patients who had deletion of their genomic class 1 MHC. And it was really clear that if you don't have class 1 MHC, you're screwed. I mean, that's the bottom line. It doesn't matter what you do with T cells. But then there's severe exhaustion, all these other receptors like LAG-3, and then of course production of soluble factors. That's a big one at our institution. Adenosine. We have adenosine deaminase expert who's trying to reduce adenosine levels because that suppresses T cells. Indolamine dioxygenase, which can eat away tryptophan in the tumor microenvironment and suppress T cells. So all these things come together, and everyone's tumor, you can sequence a tumor from here in me and one from over here, and you're going to find a lot of differences between those two tumors. So we might call it, melanoma, but the fact is they're very different. So every patient you treat has different cancers in their body if they have metastatic disease. I like this review article I read this was back in 2020, where they just kind of divided it up into external mechanisms and internal mechanisms. It helps with the medical students and the fellows and stuff, but you can see with the external mechanisms will be your metabolites like adenosine, regulatory T cells, myeloid-derived suppressor cells, and internal mechanisms are gonna be things that are directly related to the T cells, and you can have defects in antigen presentation, that's class 1 MHC, right? But then also lack or exhaustion of T cells. And it's a little known fact, but if you look at the tumor infiltrating lymphocytes in anyone's tumor, they all are expressing high levels of PD-1. They all are expressing high levels of PD-1. And in fact, Steve Rosenberg used to isolate them in the lab using an anti-PD-1 antibody. That's how high the expression levels were. And so he was the one who really came up with this concept of, hey, well, if they're exhausted or there's not enough of them, why don't we just make a bunch of them and put them back in the patient? And that's what TILs started with. We would send patients back then to Bethesda to see Steve, or we would send them, sometimes MD Anderson had a good trial open, sometimes Seattle had a trial open, and it wasn't easy for them. I mean, to send a patient who's refractory to anti-CTLA-4 at the time and then anti-PD-1s, to get them on an airplane and send them off to these faraway places. And I tried to get it open at my center, but I realized very quickly I was going to need a GMP facility, which I didn't have, and that was going to cost $3 million, and I was going to have problems with insurance. And so one day this is why this is the history lesson. In 2015, actually, I was at Moffitt. I was on the study section for their P30 NCI designation. And this guy comes up to me after, all the reviewers sat on a stage like this. It was really weird. And this guy comes up after me and he remembers me from medical school. His name's Jim Muley. And he worked in Steve's lab as a postdoc. And I'm talking to him and I say, yeah, I wish I could get TILs at the University of Louisville, but I can't. He goes, they're going to form a company. I'm not allowed to say what the name of that company was though. And so they're going to form a company and do this. So I got involved with the CEO and I said, hey, can we open it at our center? And we opened it in 2016 at U of L. So we've been doing this for a really long time. And has anyone here done TILs? have you done, other than Rob? I know Rob has. Rob has. No. Okay. So this is just a quick tutorial of what we do, basically. So you get a surgeon, they cut out the tumor, right? So I have 3 surgeons I work with: head and neck, lung, abdominal, right? And then you take that and you chop it all up, isolate the T cells, expand them ex vivo to on the order of literally 50 to 60 billion cells. And then you take the patient, lymphodeplete them with a regimen that's cyclophosphamide 60 per kg, and fludarabine is 25 per meter squared. So it's really light, non-myeloablative, light lymphodepletion. We never had a problem with lymphodepletion until after the pandemic, but the big toxicity comes once you give the infusion. You then do 2 days of high-dose IL-2, but we were pretty adept at that because we had used it for so long. So we didn't have a problem jumping on this. And what those cells do essentially is they blow holes in the melanoma cells. That's how it all started in melanoma, with perforins and granzymes, and they release interferon gamma and TNF alpha and everything else. And so this is sort of the procedure that happens. Again, this was with the original melanoma trial. And you get the patient, you identify the site you want to resect. You always had to have a second tumor to follow, of course. You resect the tumor, the TILs get produced in a lab. Then once you have good numbers and everything looks good, you put the patient in the hospital, you give them lymphodepletion. I always call it Cy-Flu because I give the cyclophosphamide first, but apparently the BMT group calls it Flu-Cy. I don't know. And you lymphodeplete them, you give them the TILs, then you give them a couple days of high-dose IL-2, and then you wait for their counts to come up and you discharge them. That's basically how it all works. And it's pretty straightforward if everything goes well. So it turns out we were the top center in the country to do this trial. And we did 153 patients. The median prior lines of therapy was 3, so they were heavily pretreated. They all had gotten an anti-PD-1 on this trial because this was 2016. And then the most had gotten the doublet as well. High tumor burden, no surprise there. The objective response rate was only 31%, so not so hot. And the median duration of response was not reached when we did this study. This is something I never heard about, so I always have to show it to people. This is a Sankey plot. Is there a statistician here? Has anyone heard of a Sankey plot? This is a Sankey plot. Each one of these lines is an individual patient. And what you're looking at is first line of therapy, second line of therapy, third, fourth, 5, 6, all the way out to the 9th line of therapy, which was the TILs, and that this single patient had 9 prior lines of therapy on the trial. So these were really heavily pretreated patients. And there's currently open a trial at our center and others, which is frontline TILs. But it's really hard to give someone frontline TILs because of the toxicity compared to just giving them ipi-nivo outpatient and stuff like that. So it's accruing super slow. But these waterfall plots, we look at these days and no one goes, oh, wow. It used to be, it was completely flipped. Everything was, all those individual patients, I forgot who was talking about the individual columns, but would go up, not go down like this. But you can see what happened in the PD-1 refractory population here. The swimmer plot looked good. There's going to be, this is a spoiler alert too. I got a spoiler. It's at JCO for a second round, but we're going to have 5-year data on TILs. And it's going to be about 20% survival. That's I can't say more than that, of course, because it's and this will all be posted, so I have to be careful what I say here. But it's about 20%. So I have to treat 5 people with TILs with melanoma to get 1 to survive. But if you treat, I'll probably see about 50 melanoma patients next week. If you treat enough melanoma patients, you get a lot of long-term survivors, which is good. Toxicity is all due to the inpatient stay with the lymphodepletion and the high-dose IL-2. There's virtually no toxicity after that. We'll get things like, bad vitiligo, things like that, that happen in the patients, but most of the toxicity is just related to the inpatient hospitalization. The FDA finally approved it. This was very difficult for them because normally you have to have a way with the product that you're going to give the patient to determine efficacy. You can't just make TILs and stick them in without having some measure, and there wasn't a good way to do that. The only way to really do it, and we tried it a couple times, was to take the TILs and then culture the patient's own melanoma cells and then use that as a surrogate marker for potency, let's say. But it was so variable that we had to kill it and use other measures. But they eventually approved it based on our data. It was approved last February. Now it's open at, I think, 70. I think there are TILs available at 70 sites across the country now. But initially, for about the first year, I'd say, they weren't open at most sites. We were having people fly in from California and Florida and Texas. MD Anderson was sending us patients at one point. But now it's approved, and it's the first approval for stage 4 melanoma that has been definitively shown to work in the PD-1 refractory population. And so I've got a couple clinical examples to show you very briefly, and I'm not going to go through all this, but patient with melanoma has a recurrence, gets some radiation. This patient came from UK, I think. Then ipi-nivo, and then showed progression with hepatic metastases. And so you can see he had pretty bad disease. Without any available trial or anything, he would have been dead, I would guess, in a month or two from when this scan was taken. He got TILs and had a CR, and I actually saw him in the clinic about a month ago. He's doing really well, and he's that 1 in 5 that responded. A second one with it works in mucosal melanoma as well. She had a lung lesion, you can see right here. After the TILs, it basically went away. Also had a hepatic lesion on an MRI here, went away, doing great. This lady's from Nashville. This lady, it's a funny story. She got written up in one of the university's magazine. She went to Vandy. They said, "You're too old." She's 73 years old at the time. She goes to MD Anderson. They say, "You're too old for TILs. You can't." And then somehow she got a hold of me through my secretary, I think. And I said, "Well, why don't you come up to Louisville and I'll check you out," right? And she was a retired school teacher. And she had a perfect cardiopulmonary system, non-smoker, 73 years old. And so we treated her, and she had, yes, a CR, and she's still alive. She's now 77. And I get to do telehealth with that dumb dog in front of her face every time. I telehealth with a dog. Yeah, but she did this lovely quote. I always like to read this. "I look out over the farm and it's so beautiful." Sometimes we forget why we do what we do, right? And I think how blessed I am to be able to be here to see this. How many people have been told they wouldn't be here for long and have not had the chance I have had? So she was told essentially, "You're toast," right? And she was trying everything to stay alive, and TILs saved her. Now TILs, TILs are tumor agnostic, right? I mean, there's nothing specific about them. We're just taking the cells out of the tumor and expanding them, trying to override all those immunosuppressive activities. So a phase 1 trial has been done. We have a phase 2 open right now in the second line for non-small cell lung cancer. So for those of you who do lung cancer who are in Tennessee, I have 3 TIL protocols open for non-small cell lung cancer right now. Three. One's a second line, and the other 2 are genetically engineered TILs. But they're TILs that we modify. I'll briefly speak about those. But here's an example of a non-small cell lung patient who had progressed, and you can see her tumor there, and it disappears. And I joke about it, but with the medical students, I was like, "Look, the tumor in the spleen went away," and then they realized that the spleen had went away because we used the spleen for the tumor harvest. You're getting all my jokes. That's great. Only one, right? And so here she is. And she's been I'm allowed to say her name and everything, but she's doing very well. Interestingly, these TILs express high levels of PD-1, and in the protocol for this arm, they got 2 years of Pembro after they got their TILs. And the medical oncologist, who was a trainee of mine, but she was a referral, stopped. She just didn't want to affect the trial, so she stopped the Keytruda. She stopped the pembrolizumab after 2 years, and I was like, "What?" After 3 months, she had progression. Now she's on ipi-nivo, doing okay. But anytime I have a TIL patient, if you refer a TIL patient to me and then you're following the patient when they come back to you, if they have any, I would say the word evolution, in all honesty, a tumor that hemorrhages or gets a little bit bigger, some enlarged lymph nodes, anything like that, I just slap them right on an anti-PD-1. I just think it's well worth it. In a second example, I'll just show you real quick here. The tumor, I think, is right here. This is a collapsed lung, And at day 42, we had a dramatic response, as well as all this hilar lymphadenopathy. And then cervical cancer, which isn't open now, but I have a lady who was from Knoxville who got TILs for cervical cancer, and I don't have her follow-up scans, but I do have her reports. But she progressed on everything, and now the last scan, whenever I made this slide, January 2024, showed she's alive and well. So it works in cervical as well. Oh, there she is. She was on some news thing, and I'm blanking on her name, Jennifer Phillips. And so at our institution, we have something called a CyTOF. Does anybody know what a CyTOF is? Nobody knows what a CyTOF is. Okay, I get to explain what a CyTOF is. So does anyone know what flow cytometry is here? Well, the only difference between flow cytometry and CyTOF is the antibodies that you use aren't hooked up to fluorescent dyes. They're hooked up to very stable, heavy metal isotopes. And if you remember your periodic table, there's a lot of those things. And so you can do up to, I think it's like 60 different markers at once. So the number of differentiated T cells has grown dramatically with the technology. And we have a CyTOF, and we're analyzing responders and non-responders, trying to figure out why do some, just like with the PD-1 resistant population, why do some people respond and others don't? And this is my second to last slide. So I can slow down a little bit. And so right now we have an endometrial cancer. I've become a gynecologic oncologist now. So we have a TIL protocol open for endometrial cancer, and it's looking good so far. Non-small cell, I mentioned. Non-small cell and melanoma, we're doing genetically engineered TILs. With non-small cell, we also have a second-line TIL protocol. So it's second line. The caveat with that is you have to have chemoimmunotherapy. It can't be just immunotherapy or just chemotherapy. It has to be, and 9LA is fine. You can have that, or you can get carb-pem-pem or whatever. But if you give them ipi-nivo up front because their PD-L1 expression is really low or something, then that excludes them from the second-line trial. But they're still eligible for these trials. So there's this one, PDC-D1. Does anyone know what that is? That's the gene for PD-1. So you're learning all sorts of things today. That's the gene. I didn't know what it was either, by the way. That's the gene. So it's a PD-1 knockout TIL. So that makes sense, right? You knock out the PD-1, you think you're going to get like more sustained cells, that sort of thing. So that's open. I really like, this is something that we're doing homegrown. It's only in the lab. It hasn't made it to the GMP facility, so we don't even have the trial right now. But I really like this one, inducible IL-15. And what this is it's a fusion between IL-15. IL-15 is a T cell growth factor, basically. It stimulates them, it activates them, it promotes their durability in the circulation. Receptors are used commonly in CAR, the sushi receptor. Everybody knows this stuff. But what this is it's got a drug responsive domain that is fused to IL-15. And that domain has a linker that is sensitive to proteases. So if you don't have the drug on board that it responds to, then the IL-15 just gets degraded by the protease. And the drug in this case is acetazolamide, which is Diamox. It's an old diuretic that we used to use. And so that drug stabilizes the IL-15, and that allows us to actually increase the TILs by giving them a simple FDA-approved oral diuretic, and then we can take it away and the TILs will go down. And we can track them because they're genetically engineered. So it's like a rheostat. We can tune the response, and if the patient progresses and you want to go to another line of therapy, that line of therapy can be, and I've done this, acetazolamide. So it's really kind of cool how it all works. And that's the beauty of TILs, is we can take them out of the body and we can mess with them and then put them back in the body. And so really the sky's the limit, in my opinion. And so here's the inducible IL-15, and you can see it's open. The trial's open. I like this slide because it's open. I always said, like, a lot of these trials that we want to participate in, they're all on the coast, right? If you're in California or Texas or Florida or the Northeast, but then you get to the middle part of the country and you're screwed, right? I mean, that's the bottom line. And so here we are right here. And we submitted it to ASCO this year, and I got an oral. It's going to be on Monday, June 2nd at 9:45. So I can't show that data now, but I can show the data, if you're at ASCO, which is good. And I jumped over the whole concept. I mentioned it already, but you can see. So you get your TILs out, and then you transduce them with this fusion of IL-15 with the drug responsive domain, and then you give acetazolamide, and you get the release of the IL-15, and that'll stimulate the TILs themselves, but it also stimulates bystander T cells, which in turn we think is going to translate into better results. But I can't tell you whether it does or it doesn't. And so here's my screwed up conclusion slide. We put it all on this template. It looks like everything got messed up, but cell therapy is very promising. TILs, again, I feel like in 10 years, I'm going to have a slide that shows TILs, probably genetically engineered TILs, being FDA approved for multiple other solid tumor types. We've been doing this since 2016. So if you're a new center and you want advice, you can call me. My number's sitting right there. And in my opinion, I think that this is going to be an important addition to the overall armament we have for treating solid tumors moving forward. And I'll stop there and take any questions.
Questions for Dr. Chesney?
What's the average manufacturing time been for the non-small cell?
Yeah, so so for melanoma, starting there, it's out to 4 weeks now, because the FDA required all sorts of extra stuff to do in the last week. They're made by 3 weeks. For non-small cell, it's still 3 weeks, 3 to 4 weeks. If you get into the genetically engineered trials, then you get out, it adds about a couple weeks. It's not trivial, but just like I can get people on trial quicker than I can with insurance carriers, right? I have to do single case agreements for the commercial TILs. So you're looking at, normally I would say it's 2 months from the referral. I can get the harvest done fairly quickly, but then you got to wait the month. But once we get good numbers, we can put the patient in the hospital and start the lymphodepletion with the, I'm not allowed to talk about pharmaceutical companies, but one is 7 days lymphodepletion and one is 4 days.
Dr. Chesney is here.
Yeah, oh, hi.
It's a great talk, actually. Really, it's working very well in your hand. I have naive questions. When you isolate the TILs from the patient, it may have both. It's like heterogeneous, right? Both effector as well as exhausted T cells will be there, right?
Yes.
Do you have a pipeline only amplifying the effector T cells instead of the? So
yeah, the cytokines that are added are specifically added to expand the central memory effector T cells. Now that doesn't mean that you don't see NKs in there. I mean, we've if you go to the paper, you'll see it's one paper before the one I showed you. It's in JCO. Just search my name in Journal of Clinical Oncology. You'll see it. That we analyzed all the subtypes in the TILs because we were trying to find out if one subtype would reflect responses or would correlate with responses, and we didn't see anything. We saw no correlations. So I don't know. Yeah. I'm afraid to shift it towards what we think it's going to be. Right? Because if we do that and it's not the central memory effector CD8 positive T cells, then it'll be a negative trial.
Yeah, that's true. And then the second question is you are infusing one time?
The TILs?
The TILs?
Yeah, well, yes, it's one time. It's usually in 2 or 3 white milky bags, but yeah, it's one time.
One time.
Yep.
And it's completely eradicating the tumors. It is removing the tumors, right?
Well, we're getting an objective response rate by RECIST of 31%.
31%.
With 153 patients. That's melanoma.
Melanoma, right?
Yep.
What happened to the TILs after that? Whether it will become exhausted or what will happen to them?
Yeah, so that's a interesting, there's an interesting observation that I have personally had, which is that lady with the spleen, right? I showed you, but then there's a gentleman from Knoxville who had a motor vehicle accident 20 years ago, and he didn't have a spleen, and he had a complete response. So I have 2 people who don't have spleens, both of whom have had a complete response. So I think the TILs are being cleared. TILs are basically damaged T cells, right? I mean, we've exposed them to all this crap in the lab, and growing them out, and so your spleen eats them. The macrophages in the spleen eats them. And I think we could probably get a better response rate if we took the spleen out of everybody, but nobody wants their spleen removed. I don't know why. If you're dying of stage 4 melanoma, right? I said it was going to be comic relief. Come on. I'm trying to keep everybody awake before it.
I got to ask a practical pharmacist question. We're excited. We infused our third patient in Milwaukee this week.
Oh,
so
great.
We're excited.
Great.
So
we shouldn't say the name. The
yes,
commercial
our
TILs.
pharma part. Yeah, we had a couple on trial, maybe 10, and a cervical patient too. But as we know, the IL-2 number of doses doesn't correlate with response. I was just going to ask, I have kind of a generic answer from pharma partners, but on average, how much do you push that, or how many doses are your patients getting? Most are getting 5 or 6, or
it's like apparently it's on Facebook. All these people patients getting TILs talking about high dose IL-2. No, so what I do is I give the first dose, and then we transferred the procedure to the bone marrow transplant group at our institution. So they do it in their unit now. I think it's just safer for them. And we've seen a lot more toxicity with, like I said earlier, with lymphodepletion after the pandemic. I think we know that 80% of patients who had COVID have changes with a cardiac MRI. So they're more sensitive to cyclophosphamide and fludarabine. So we'll see arrhythmias, SVTs, all sorts of things that we'd never used to see before the pandemic. But when you get to the high dose IL-2, I always say the same thing to all the physicians who are giving it, which is any excuse not to give the second one is appropriate, right? And so little things like, the patient's uncomfortable or high fever or tachycardia, any tachycardia or hypotension, you always stop it, right? But there's not been a randomized trial doing high-dose IL-2, doing TILs with or without high-dose IL-2. We do not know if it is beneficial at all. There's I think it was a one correlative study that was done years and years ago looking at the dose of high-dose IL-2, and there was no change in the response rate, but it was in like an N of 5 patients or something. It was done at the NCI. So we really don't know. So I still give the first dose, but then I have a very low threshold to stop it. Yep.
Any other questions for Dr. Chesney? Great.
I just wanted to say Rob has done an outstanding job putting this meeting together, and I really appreciate him putting the meeting together because I think I learned a lot during the meeting, and everybody give him an applause.